Possibly, yeah. Remember, it's a nerve root tension sign. So whatever's going to create tension on that nerve root, whether it be a disc lesion, sometimes stenosis or arthritis, where that IVF is, can occlude that nerve. So with the straight leg raise, I'm going to have you lie flat on your back. If this is the affected side, you're going to just slowly raise that leg up. And as you're doing it, watch the patient's face. This one is not only visual clues, but also verbal. Like, let me know if any of this hurts. Usually, remember the first 0 to 15 degrees, it can accentuate muscle spasms in the back or cause muscle spasms in the back. After 15 degrees, once we're about 45 degrees, it's causing a lot of tension on those nerve roots. And this, if there is a disc lesion or if there is a pinched nerve type of a lesion, this is where you're going to find pain. And you would ask the patient, does that hurt? Yes, it does. Where does it hurt? Well, it hurts, here. I'm getting pain down the leg. I'm getting tingling into the foot, which is further confirmed that there's a positive nerve root tension sign. Then, remember, Braggards test. Once you get to that point of pain, they say it hurts. Let it down just a little bit, and then you're going to passively dorsiflex that foot. Again, creating more tension on that nerve root. It's not on there, but remember Touryns test? Remember, that's just extending the big toe. And that's, if this is positive, you just go in there and push that big toe towards their head and that hurts. They have a really, really hot disc, a really acute disc. What about well leg raise? Yep. Remember, with the well leg, if this is the affected leg, this is then be the well leg. Normally, there shouldn't be. You should be able to bring that leg up, and there should be no tension or no irritation to the affected side. If you start bringing this up and it starts to cause back pain and leg pain on the affected side, that's a positive well leg raise. Positive well leg raise can indicate usually a very large medial extruded disc. So usually if a well leg raise is positive, you're dealing with a pretty large disc. But that's not such a bad thing, because remember we talked about in the treatment of disc herniations, disc extrusions, usually larger discs respond a lot better. They can take a little bit longer, but they have a better, sometimes with the absence of like Cauda-Equina syndrome. What is Cauda-Equina syndrome?
Inflammation of the tip of the cord, right? What's the tip of the cord? Something with it.
Remember, it's compression of the spinal nerves, and it can cause bowel bladder loss.
But it's right where the spinal cord ends.
The Cauda-Equina is where it splits, but the Cauda-Equina syndrome itself is when there's. Remember we talked about the saddle paresthesias?
Oh,
so they're numb in the genital and in the buttock area. The patient, sometimes they will have urinary, just all of a sudden go to the bathroom on themselves, either bowel or bladder dysfunction. Sometimes they just can't go to the bathroom too. Very rare, but that's the only time if, you do a well leg raise and they're also having those symptoms, that's an immediate send them out to the ER because they're going to need an emergency decompression, surgical decompression. Any questions on those so far? So Bectrews. So can you sit up for me, please? And just let your legs hang off to the side. Bectrews. What are we looking at with Bectrews? Pretty much the same thing, but it's the seated version of the straight leg raise. So you can do this actively or passively. So if this is the affected side, can you straighten that leg all the way out? And usually they should be able to do that. If there's a pinched nerve, disc lesion, when they do that, it's going to cause back and leg pain. Then you would have them do the opposite side. Again, that's like your well leg. And then you would have them do both at the same time. So we were like 1, 2 Bectrews. So it's an easy way to remember that. But again, it's a seated version of the straight leg raise. Then depending on, so if we suspect a herniated disc, what type of a test could we do, or what special test would you order to rule in a disc or rule out a disc?
X-ray or
MRI would be more specific. Yeah, MRI would be more specific. Remember, you can't really see a disc on an X-ray. You can evaluate the spacing between the vertebrae, but an MRI is going to be your test of choice to rule out and rule in a disc herniation. So Kemp's test. Kemp's test can be, you can perform it either while they're sitting or while they're standing. So because the video is here, I'm going to do it while she's seated here. So let's say the left is the affected side. Remember, you're going to, you can put your arm over the shoulder. With the other hand, you're going to go in that, remember that paraspinal gully, so to the left of that spinous, and you're going to laterally flex, rotate, and extend that patient, and just a little bit of overpressure in that area. If there's local pain, what would you suspect? Perfect, yep, facet syndrome. If there's radiating pain, what would you suspect?
Disc.
Disc or, yeah, some sort of nerve root lesion. Remember with the facet, localized pain because the facets are imbricating or rubbing against each other. That's why there's going to be localized pain. Sure. So I'll do it on your side now. So you're going to laterally flex, rotate into your hand, and then extend. And you get a little bit of overpressure depending on which side you're testing. Local pain, usually facet. And usually remember with the facet syndrome on your range of motion test, usually, active range of motion, when they go into extension, there's going to be pain as well because that's causing, again, those facets to rub or to touch. When you usually flex, usually at the end point of flexion, there's going to be pain because it's causing some irritation to the facet as well. Yeoman's test. What are we looking at with Yeoman's test? What structure? Excuse me? SI joint. No, man. So can you face down, please? So with Yeoman's test, you're going to grab the lower femur like this. Remember with your thenar eminence, you're going to go right over the sacroiliac joint. You're going to passively bring that thigh up or extend that thigh, and you're going to push down with this hand. You're going to stress that sacroiliac joint. You're looking for a verbal, hey, that hurts. And again, that can be an indication of an SI lesion, whether a sprain or that SI joint is inflamed or just that it's a hypomobile or the joint's not functioning correctly. And that would be a positive Yeoman's test. Nachlas, the Nachlas test, you're just going to bring that heel to the same butt. And this is another test like Eli's, where by doing that, sometimes if the anterior muscles are tight, it's going to contract on the femoral nerve and cause some issues. But again, this is that type of test where you're going to observe to see if that hip rolls up at all, but you're also going to ask the patient, does this hurt? Yes, it does. Well, where does it hurt? Does it hurt? And they might say either low back, SI, or the hip. So it's going to help you differentiate what's going on. What's not on there, and I forgot to put it on there, another sacroiliac test is Gaenslens test. Gaenslens test, again, that's going to be to check the SI joint. So with that test, can you turn over on your back again, please? So if we wanted to evaluate the left sacroiliac joint, you're going to have the patient bring the right leg up, have them as close to the edge of the table as possible, and let that leg just hang down. That's going to strain the sacroiliac joint, and that should cause pain, and that's a positive Gaenslens test. Any questions on those so far? Why don't you guys perform all the low back tests?